Okay, hi everyone. Welcome back to another session with Fresh Dental Shadowing. Today we have Dr. Sahib Soliman, and he's a chief resident at the University of Buffalo for his OMFS residency. And yeah, take it away whenever you're ready, Doctor.
Awesome. Thanks, Zainab. I really appreciate you guys having me. I love kind of just being involved with any pre-dental organization and, giving you guys any insight I possibly can into the process. I know it's a little bit different having, may not be practicing general dentistry, but it's actually funny. What got me into dentistry originally was OMFS. When I first started working in a dental practice, I was originally kind of on that like med school track slash dental school, wasn't sure exactly what I wanted to do. And then finally, like I started working for a general dentist, started, liking some aspects of dentistry. And that's kind of when I found out about OMFS and realized that, hey, you know what, this actually is a pretty sweet specialty. And actually, funny enough, it wasn't until I actually started residency that I actually realized just the immense scope that we practice. Because all I knew was the oral surgeon that you'd see down the street, that knocks people out for their wisdom teeth, and that was about it. So being able to actually, live, eat, sleep, and breathe it is actually completely eye-opening. I'm hoping to be able to kind of, impart some of that knowledge on you guys and give you guys kind of a heads up on, what you may experience should you decide to head down that field. So OMFS itself. So what exactly is OMFS? So again, OMFS, people say oral surgeon, but in reality, we're actually oral and maxillofacial surgeons. So internationally, we're recognized as, basically head and neck surgeons. We treat almost everything from the head, skull, neck, face, jaws, and mouth. Actually, even some OMFS guys will do additional fellowships and do actual cranial-based stuff. So it's like pretty much as close as it gets to being a neurosurgeon without being an actual neurosurgeon. But otherwise, it's for the most part, you're a head and neck surgeon. We're recognized by the American College of Surgeons. It's interesting. The specialty itself in North America only really is a specialty of dentistry, where people go into dental school first, and then will then specialize into oral and maxillofacial surgery. And the rest of the world, people pretty much go into it from the medicine side. So there's actually, you'll find in some countries in the world, there's an oral surgeon that's like basically just strictly dental trained. And then there's an oral and maxillofacial surgeon who's actually medical trained. But in the US, we'll focus on that specifically since I doubt any of you guys are going to go overseas to be OMFS. But here in America, you either can practice as an OMFS with just a single degree, a DDS or a DMD, or both an MD and the DDS and DMD. So you basically get dual degree, both a medical degree and a dental degree. A lot of people ask, what is the difference between, should I have a single degree or should I get the medical degree and the dental degree? So I'm actually myself, I'm a single degree only. So I'll be graduating as a DDS only. I don't have a medical degree, but my other residents in my program, some of them have MDs since I transferred in on a separate track. But what's interesting about that specifically is that people, the MD is cool. And yeah, it's awesome to have an MD. But from a strictly based scope of practice for OMFS, there really is no difference in scope. What the MD does is it allows you the additional training that comes with like the medical degree in terms of the other fields of OMFS, or excuse me, medicine that aren't specifically surgery, like psych, OBGYN, things like that. And then also on the flip side, it does open more doors to doing additional fellowships because a lot of fellowships actually require a medical degree in combination with your DDS. So if you want to be just a strictly bread and butter OMFS surgeon, it doesn't really matter. If you want to pursue additional fellowships, that's where the MD can really come in handy. And then in terms of the fellowship training, so what exactly can you fellowship train in? So every OMFS, depending on which program you go to in the country, has a pretty wide scope of training. Some programs are very broad scope where they do basically everything you see there on the slide here. Other programs are more kind of like smaller in scope. They'll do more just dental alveolar. Maybe they'll focus on some craniofacial surgery. Some programs are very heavy head and neck surgery. I'm lucky at University of Buffalo. We're heavy in both head and neck, craniofacial, and dental alveolar and orthodontics. So I'm getting kind of the full gamut of stuff and some TMJ as well. We don't do a lot of facial cosmetic surgery here, but if you are interested in doing cosmetics, you can then pursue that further in a fellowship. So if you do want to become more focused in a specific field that you like, you can continue the training post residency to become even better in head and neck cancer or craniofacial or cosmetics, whatever your heart desires. So let's focus specifically on the actual training it takes to be an OMFS. So I know a lot of you guys are interested in, or maybe interested in doing OMFS initially, but you still have to go to dental school. So every OMFS has to do 4 years of dental school, whether it's a DDS or DMD. There's a little bit of, and I actually can't speak too much to that for some of the international students, because I know some international people try to apply to OMFS in the country, and I'm not sure if any of you are international, but either way, most of them require an American DDS or DMD, unless you're like a random, like this weird fellowship position. And a lot of them require like US citizenship. So I'm assuming the majority of you are either US citizen, green card, or are planning on practicing or work, excuse me, getting your DDS in America. But specifically the 4 to 6 year program. So if you're just a 4 year degree, so like I was, so the 4 year degree, what it was is we did pretty much, you do 4 straight years of training with OMFS. And then when you compare that to the 6 year program, the additional 2 years are what you spend in medical school. So those additional 2 years is where you get that medical degree. So that's where you spend. It could either be your second and third year of medical school or your third and fourth year of medical school if you compare it to a normal medical student. And when you spend that time, you do the rotations and those other specialties that I mentioned that aren't specifically really related to OMFS, but that's what you need in order to get the medical degree. You also have to take the step 1, step 2, and step 3 tests. But after that, then you get your MD. But for the most part, we all have the same level of training in terms of OMFS itself. It's just the difference in the actual surgical side is that instead of doing 12 months of general surgery, I only did 6 months of general surgery. And then on vice versa, we do the same amount of general anesthesia. We all do 5 months. We do a little bit more internal medicine. So the two kind of vary, but for the most part, you're pretty much identically trained when it all comes in the end. And then again, it's up to you to decide where you want to go. You can either, some programs are 4 year only, some programs are 6 year only, and some programs actually offer both the 4 year and 6 year track, and they kind of integrate them together in terms of the OMFS training. So again, some places overseas will actually allow you to go into the dental degree, or excuse me, a medical degree. And what they do is they do 6 years, but instead of spending the 2 years in medicine, they do 2 years in dentistry actually. So they can become a full OMFS surgeon. So this is kind of a very interesting fact, which I don't know if a lot of you guys know, but the world's first face transplant that actually occurred in France was actually performed by Dr. Bernard Devachel, who was actually an oral and maxillofacial surgeon. So that immediately should kind of give you a heads up on just how broad our scope is, that the first face that was ever transplanted in the world was actually performed by an OMFS. So I mean, we're pretty heavily trained in the head and neck area. So what I want to do is kind of break down the specific parts of OMFS and kind of tell you guys what we do as a full scope, so you kind of have an idea. So oral surgery, this is where you really kind of, and this is why the general public calls us oral surgeons, because 90% of the specialty will end up, despite being incredibly well trained in the head and neck surgery, will then just do only really the dental side and oral surgery side, which is, what you hear about, person went to their oral surgeon to get put to sleep, to have their wisdom teeth taken out. They put in dental implants. They do like some of the soft tissue grafting in the mouth, some of the sinus surgeries, or even just basic oral pathology. And the reason why the majority of oral surgeons go into this, and I'll be frankly honest with you guys, it's just the lifestyle. When you work more on the dental side and less of the hospital side, there's way less call involved. The pay tends to be higher. You're working that 4 days a week if you want. You have that cushy lifestyle versus someone who's doing more of the intense specialties in OMFS, tends to live more of that medical life where you're on call more often. You have those very long surgeries where you're there for, until 7, 8 at night versus getting out at like 4 or 5 during the day here with just your general basic dentalveolar surgery. So this kind of gives you an idea of what we do within the oral surgery spectrum. As you can see, like on this upper left side, we place all those dental implants so we can give people restorations to actually be able to, function on an edentulous ridge. So a ridge that doesn't have any teeth at all, we can then slap on as many implants as we want and actually give them, fixed hybrids and give them bridges. Basically, whatever the general dentist wants us to do, we can make it happen surgically. On the upper right side, that's something called a sinus lift. So if someone, as you get older, you actually, and I don't know if you guys can see my cursor here, but as you get older, these sinuses that you can see in this x-ray will slowly do something called pneumatization, which means that they slowly will head down closer to the roots of the teeth. Especially if you lose teeth, they actually will end up dipping down where they're so low, there's not room to actually, or not enough bone to place an implant there. So what we do is we go in there and we actually make a little window on the side of the sinus, and we will pick up the sinus membrane and pack in bone underneath, and that way and close it back up so that bone will heal. Then we can actually place an implant in that area afterwards. Some of the stuff we do sorry, let me go back a slide. So this, what you see here is like an example of the wisdom teeth that we take out. So wisdom teeth are your very far teeth on all 4 quadrants. These wisdom teeth here, if they're hard enough, no general dentist wants to do it, so they send them to the oral surgeon to do it. So this is kind of the bread and butter, we call it, the wisdom teeth that we take out. But we also take out some pretty darn hard ones. So these are already kind of hard enough as is. Sometimes you get patients whose wisdom teeth are actually like in the actual mandibular ramus, some that are actually like sticking down through the inferior border. These are what we call kissing wisdom teeth, in the sense that they're actually growing completely opposite directions and like a cyst in the middle. So we do some some of the more very complex and very difficult extractions where, you're at very high risk of nerve damage. There's a nerve that gives you sensation to your lip and your chin that runs through this jaw that if you cut it, people are numb in their jaw for the rest of their life, which can be pretty debilitating for some people. Another thing too is, they're very high risk of fracture of the jaw. So if it breaks, we're also comfortable fixing it if that happens during an extraction. So you can see we're very well trained for some of the harder stuff. This is actually an example of a wisdom tooth, and I know some of you guys probably aren't trained yet in reading CT scans, so I'll walk you through it. But this is a wisdom tooth here. This faint kind of gray line that's running to the base of the wisdom tooth here, that faint gray line is actually your nerve that runs through your jaw. This nerve just happens to be running through the middle of an actual something called cementoblastoma, which is actually running through the root of the tooth. So you can imagine if we try to pull this tooth out, we're just going to cut the nerve right in half. So we actually had to go in as OMFSs and make like a window in the side of the jawbone and literally dissect the nerve out. You can see where the nerve courses on the upper left image. That little groove right at the bottom of the ruler, that's actually where the nerve used to course right there between that thing, the cementoblastoma. So we actually split it in half, teased the nerve out, and then took the tooth out that way. So it's almost like, it's kind of funny. I almost liken it to really neurosurgery because you're really dissecting nerves out of different structures in the jaw. This is an example of a CT scan where sometimes this happens and it's not anyone's fault because it happens to anybody. It'll probably happen to me at some point in my career. But sometimes dentists, when they're extracting teeth, they can push a tooth up accidentally, one of the roots up into the sinus itself. And it's not that hard to do when the bone is very thin, like in this patient. So when the roots get stuck in the sinus, they end up getting these big infections, which is all this. You can see here on this left CT, an infection is kind of all this colored filled in tissue here versus like a clear normal sinus on the right side here. So we go in there and we make little windows in the bone and we actually will dig those roots out that are still stuck in the sinuses. So that's kind of your basic bread and butter OMFS. Now, the part that not a lot of people know about is this is what we're going to start diving into. So one of the cool things that I love about this specialty is the trauma. I mean, we're just like any other head and neck surgeon. We actually rotate through trauma call at these level 1 trauma centers with both plastic surgery and ear, nose, throat surgery at many different hospitals in terms of like the trauma that comes in. So we deal with adults, children, we deal with full fractures of the skull, anywhere in the skull where a bone is broken, minus the top of the skull, the calvarium, or the back of the skull, which tends to be neurosurgery. We pretty much cover. And even at some programs, OMFS will cover those bones as well. Soft tissue trauma, no matter how bad somebody's face is cut up or torn open or scalps completely avulsed, we take care of all of that. Neck trauma, whether you're involved with the carotids, the jugulars, any of the big trauma to the neck, we deal with that. And we're pretty much consulted on all mid-face and mandible or maxilla traumas because we're really the major service. And when I talk about service, it's a specialty. We're the major service that can handle the mandible the best because we understand the occlusion the best. And that comes from us being dentists. We know how teeth go back together. Now, not only do we give people a good anatomical reduction where we put the bone back where it's supposed to be, but we actually give them the ability to function again on their teeth because we know what it takes to function right. So this is an example of some pretty bad trauma that we'll see. This is someone who was involved in a pretty high speed motor vehicle accident. You can see here, just pretty much the skull is just shattered all the way around. And we actually went in there and we plate every single bone back into place. We put some mesh up top to fill up the frontal sinus. We put a big plate across the jaw to put it back together. So, I mean, we're talking completely full facial reconstruction in these really bad trauma cases. This is another example of a trauma case where somebody's upper jaw was literally split in half and almost shifted completely off their face in combination with a bunch of other trauma here. And again, I apologize if this is too much for some people, but I want to just make sure you guys kind of got a scope of what we do within the surgical field. But this is a really cool reduction. You can see on the right side a very, very good result. We were able to get everything back together and as close of an anatomical position as possible to give that patient the best shot of being able to function and have a normal life again afterwards. One other part of trauma that we do may not be the actual trauma itself, but after you stabilize a patient, we're actually trained to go back then and also reconstruct these defects and give them the opportunity to look normal again. This is an example of someone who had a gunshot that unfortunately avulsed a large amount of tissue in the left side of his face. So after the patient was stabilized and everything was under control, we actually then went back, scanned the patient, and designed these new plates and these new implants to actually give them normal contour to the face. So you can see here, this is where he started here on this left side. And now on the right side, it looks markedly better because we're able to kind of bring that facial projection out, bring that eye socket out, and actually make it look like much more normal than it did before. Another facet of OMFS that's pretty interesting is our temporal mandibular joints, your TMJ, your jaw joint. We do pretty much everything that's involved with the jaw joint, whether it's in terms of like something called TMJD. You know what people always say, like, I have TMJ, I have all this pain in my jaw joint. We deal with all of that. So whether it's and there's different levels of treatment to that TMJ pain. It could be in terms of like non-surgical management. We have arthrocentesis, which is like flushing out the joint, arthroscopy, which is going in there and kind of shaving little areas of the joint, arthroplasty, actually replacing parts of the joint. You have disc surgery and the actual disc that sits in the jaw joint itself, or we actually do total joint replacements. So this is kind of a photo of some of the stuff that we do here on the upper left. This is an arthroscopy where they're going in and looking at the jaw joint and actually making little cuts in the tendons and the ligaments that are in there to try and reposition the disc to give someone the ability to function again properly. On the left side here, this is actually a total joint replacement. And on the bottom left, on the left image, you can see this is actually where we attach the new joint to the base of the skull up top. And the bottom part is that condyle part, the part of the jaw that you see on the lower right. That's actually getting fixated to the lower jaw, so you can actually start to function as if it's a brand new joint altogether. And this actually, ignoring everything I've said, my favorite part about this specialty is orthognathic surgery. So orthognathic surgery is just a fancy word for correction of actual skeletal discrepancies. So what's that mean is that you ever seen people with really bad underbites, really bad overbites, their jaw is like shifted over, they can't chew properly, and no matter what they do, they can't get those teeth back to position. So whenever people have really bad bites, there's usually two combinations that are causing that issue. One, it could be their dental. Some people's teeth are just so crooked their teeth can't get together. And some people actually have a skeletal component where the jaw bones are actually too mismatched that no matter how hard you try, you can't get the teeth back to where they're supposed to be. So what we do as OMFS is we actually go in there and we actually break these jaw bones. When I say break, it sounds intense. It's like controlled surgical management where we actually make controlled cuts, and we actually plan this all virtually 3D, scan the patient and actually get everything down just less than a millimeter. And we actually move these jaw bones in the different directions and get them to line up so patients can actually have a normal bite again afterwards. This is an example of somebody here on the lower left side. This is an oral surgeon out in Los Angeles. You can see just by looking at her face, she has a really severely deficient lower jaw. You can see it's so deficient, she's starting to get a little bit of that buckling in the lower jaw. Her tissue is bunched up. And this is her biting normally. So when he went in there and the jaw surgeon went in there and actually moved the lower jaw all the way forward to give her a normal bite. And what's interesting is whenever you move jaw bones, it actually makes a very big difference cosmetically too. You can see cosmetically, it stretched that tissue out. She has a more youthful appearance, looks younger in the neck versus what she had there. It was kind of just like closed in and all that redundant tissue down below. This is another example here, and this is kind of one thing we do is we actually combine those jaw surgery movements with actually a total joint replacement. So this is an example on this left side where the patient's lower jaw was so deficient, not only in the jaw itself, but also in the ramus, which is like the part that curves up to the skull, that she actually needed help by getting an actual jaw joint replacement to bring that jaw forward. We actually adjusted the upper jaw as well. So the upper jaw was moved as well, and we got her into a nice good bite. This is an example of another one, a young female who had a really bad underbite, and also not only that, but she's also kind of crooked off to the right. So this girl got 2 jaw surgery where we actually moved the lower jaw and moved the upper jaw. And you can see it's a pretty incredible result on the lower right side, and the difference between both jaws and her, not only the way she's going to function, but also the way she looks, she has a really good result. One other aspect of OMFS, and it's something that not a lot of people think about, is we deal with some pretty darn big infections. So nobody realizes that a tooth infection can actually cause some pretty major damage in the body. People you always hear about these stories of people, they have a really swollen tooth and they have like a lot of pain. They'll have a really big swelling around the right side of their jaw, or they'll have a swelling in the front part. But these swellings can actually spread to deeper space infections in the neck. They can spread to like below your jaw. They can spread close to your airway. They can deviate your airway. In some cases, they spread so severely that they actually can one of two things: either A, completely close off the airway and require people to get a tracheostomy, which we do, by the way, as a specialty, or they actually require them, or they can spread so quickly and so severely into something called necrotizing fasciitis, which is a specific type of, and you guys may have heard this infection where it's actually a flesh-eating bacteria. And that bacteria can actually begin to quickly eat away someone's body, make them septic, and actually kill them within 24 to 48 hours. So, and that can all happen from a tooth, and nobody realizes that a tooth can cause that much damage. So it all just depends on the patients, a lot of factors of the patient themselves, but we handle so many of these deep space infections and can actually save lives in some of these patients that could literally die within a day or two. I'm not gonna bore you guys with these specific bacteria and stuff like that, but there's different ways you look at different spaces and what can cause it. So one of the biggest infections I've ever seen was a necrotizing fasciitis that spread so far back it deviated the airway. It spread up into the space up here by the skull, into something called the deep temporal space. It spread posteriorly into the excuse me, not posterior, it spread even inferiorly along the neck down and actually in the mediastinum, so the front of the chest. It actually got down there. We actually get cardiac thoracic surgeon involved in our case as well, so they can actually do the dissection, open up the chest, so we can actually drain the chest part as well. So, and this is all from one tooth, so it's pretty scary what can happen. This is an example of a patient who had a really bad infection below her jaw. This actually was from a dental implant that was placed. And unfortunately, the dentist put her on the wrong antibiotics and just made some wrong decisions that made this spread even further. So eventually she ended up in the emergency department and we were consulted. And again, this is an example of a CT scan. And I don't expect you guys to know all this, but it's pretty obvious once I point it out. But on this left side here, that black part in the middle, that's your airway. You can see that the airway shifted all the way over, and this is to the patient's left because CT scans are like looking at the patient. But the patient's left, it shifted over to the left. And then the left side of her jaw, which is over here, like just above the airway, the other black space, that's normal space in the jaw or in the neck. To the right side, all that kind of gray, lighter stuff, that big fluid that's shifting the airway, that's all abscess. So you can see that abscess literally spreading up to the base of her skull on the right side. And it goes all the way down into her neck as well below and shifts it. So she was already having trouble breathing when she laid down. She was having trouble swallowing. So we had to go in there and literally drain all of that out. And these infections become so bad, like I said, they can develop into something called Ludwig's angina, which is spread all the way down below the jaw. I'm not going to bore you guys with the specifics about Ludwig's angina, but these ones can require they require a tracheostomy, which we do ourselves. They require multiple drainages. They require heavy antibiotics. And as a service, we're in charge of making sure all that stuff's taken care of, making sure that we are able to save this patient at the end of the day. I'll ignore you guys the Ludwig's treatment. One other thing that's actually really interesting, I wanted to show this is actually from my time during my rotation of general surgery. So I spent 6 months on general surgery. I spent some of it on the actual general surgery surface, and some of it I spent in the trauma ICU managing patients there as a full-fledged resident. This is a patient that I saw that actually had necrotizing fasciitis in the stomach. So that, in this case, that black up at the top here that you see, that's all air that was created by the bacteria. And that's one of the signs of this flesh-eating bacteria that occurs. So I went in there and it was really cool because the general surgeon that was on the case let me actually do this cutting. So I actually got to cut into the stomach, open it all up, clean up all that dead tissue that was in there, and start the process of rehabilitating the patient. So as an OMFS, even though you're getting very strong training in the head and neck, during your off service time during general surgery anesthesia, you're functioning as a resident on those services, and you actually can get quite a lot of experience doing a lot of really cool stuff that's not even related to the head and neck. One thing that we also deal with is something called obstructive sleep apnea. You might think of this as someone who's like snores really loud, somebody who has difficulty breathing when they're laying back. I think like my dad has it. Everyone may have a dad or an uncle or a grandpa who snores really loud. That usually indicates some kind of insufficiency in the airway passage between the nasopharynx or the oropharynx and down into the lungs that causes that reverberation and loudness. People don't know this about obstructive sleep apnea, but if it gets bad enough, patients can actually start developing heart issues with it as well. They'll notice that they can't sleep as well. They become actually almost like drunk drivers during the day. They found that with severe obstructive sleep apnea, a lot of these people were equivalent to drunk drivers during the day when they were driving because they had such little restful sleep during the night that it actually caused them to have major issues during the day. So we actually are involved in a lot of surgeries that can help treat this obstructive sleep apnea, whether it's actually going in there and reconstructing the posterior oral pharynx, whether it's actually moving the tongue around to bring all that muscle forward to give them more space to breathe, doing surgery in the nose to help them breathe better through the nose. Orthognathic surgery, actually advancing both jaws, can help open the airway. And I'll show you guys an example of that later. Even though some people think of ENTs as being the only ones that do like tonsillectomies or adenoidectomies, we actually do tonsils ourselves, so it can help free up some of the space in the back of the throat and help people breathe a little bit better. So this is an example of something up top here. It's called a UUP, triple P, which is like a pharyngoplasty, palatoplasty, and uvuloplasty, which is something where we go in there, we actually open up and we clean all that tissue out, basically cut all that tissue out to give them more of an open airway space, you can see on the right side. That can sometimes help people breathe a little bit better. This here on the right side, you can see there's just a little bit of an example of some of the anatomy that's involved with the airway. But if we look at the obstructive sleep apnea, this is something that's really cool. And someone who has kind of a deficient lower jaw, people don't think about this either, but deficient lower jaws aren't just a facial issue or a dental issue. But when you think about it, all that muscle that's attached to your lower jaw, that's your muscles of your tongue, the base of the tongue, some of the muscles that are involved in swallowing, opening up your airway, those are also collapsed backwards and actually shut off the airway itself. So what we do is we actually will go in there and we'll actually advance both jaws. And you not only do they get a really good cosmetic result, but also if you look on this upper left X-ray, this faint gray white line that's up on the X-ray, that's the original airway. You can see how very tight and small that airway is. When we advance both jaws, all of a sudden the airway is much wider and much larger. So this guy, and he actually didn't just get a jaw advancement, we actually advanced his chin as well separately, which helps pull those muscles forward and open up that airway further. One of the things also that we do as OmaFest is, and that's kind of near and dear to my heart because now that I have my own daughter and she's 16 months old, I start to kind of feel a little bit more for some of these parents, and it's hard not to develop a little bit of an emotional attachment to this part of our specialty. But we do a lot of craniofacial surgery with these kids. And these are kids that are born with birth defects, different syndromes, different things that are involved that can unfortunately make their lives very difficult, not only just from a physical standpoint, but also from a societal standpoint. And so we kind of go in there and we help kind of correct some of these birth defects that can occur. Like, for example, we can use the orthodontic surgery, like we said, mentioned earlier, for patients that are born with really small jaws. You can do joint replacements for people that are born also really just small jaws as they get older in age. Cleft lip, cleft palate, something I really love, and I want to do a lot of cleft lip, cleft palate when I graduate overseas. That's something that we do as well. Craniofacial clefts. Sometimes the cleft lip and palate you see can actually extend through the face and actually through the skull, and we are involved with correcting that. Craniosynostosis, that's when someone's skull is we have these sutures in our skull, and you guys may have remembered this from anatomy that help your skull expand with the brain. Some kids are born with the skull, those sutures being fused too early. And when they're fused too early, these kids run the issue where their brain can't grow properly. And it'll either push their skull out in one direction, or it'll actually start creating a lot of pressure within the skull itself and cause them to go blind and eventually die. So we go in there and we tag team with the neurosurgeons, and we actually reconstruct the entire skull to actually give them space for the brain to grow. Another thing too is like hemifacial microsomia, where some kids are born with one of their faces just way too small compared to the other side of the face. We actually go in there and correct that surgically as they're growing. Again, cleft lip is just something that I think is probably my favorite out of all these surgeries, because it can give you that immediate result on some of these kids. This is an example of someone who actually not only had a cleft lip, but actually had a facial cleft as well. So the surgeons went in there and they actually corrected the cleft lip and the nose, and they actually, and the palate, and then not only that, but helped kind of correct the nose as well, and kind of give them more of a natural appearing nose. Down below, you can see just how amazing some of the results of these cleft lips can be, and how minimal scarring these patients can have when we're done. This is actually a pretty impressive surgery that we do with an OmaFest as well, but this is something called like a facial bipartition, and that's a fancy word for saying we literally cut the face of someone and actually move the entire face forward for someone who has a really deficient entire face, not just the mid face. It's kind of like what we call a Le Fort 3 advancement, where you literally advance the entire face, but not only just a Le Fort 3, but we actually advance the frontal bone as well with that. So this is kind of the example we talk about the cranial sutures, how they develop and how they now when one side gets fused, you can see they can get that alien shaped head. If another part gets fused up front, they develop like a diamond head, and it all comes in different shapes and sizes. So we actually go in there and we actually make these cuts along those areas of the sutures, and using virtual surgical planning, we readjust the skull, reshape it with the neurosurgeons, and then close it up, and that gives the ability for the skull to reshape and grow in a normal shape. This is another example of someone that we did a facial bipartition on, where we actually moved the entire face forward. But we didn't just move this guy's face forward, we actually moved this entire face forward, as you can see here in the next slide. So we actually moved the entire face on this kid, but we also actually split his face down the middle as well and moved the two segments in different shapes, so we can actually get a better result overall. This is actually probably the biggest surgery I've ever been involved in myself, even though not including the head and neck cancer surgeries, but which we'll talk about in a second. But this is actually a really invasive surgery. We have to be involved in neurosurgery on it because we're right next to the brain. They literally retract the brain for us while we're making our cuts to move these pieces where they need to go. Cosmetic surgery, it's not something I'm personally planning on doing when I'm out in private practice, but some OMFS guys love cosmetic surgery. They'll do facelifts, chin lifts, Botox, facial peels, they'll do nose jobs, lip augmentation. I mean, you name it. Anything that a plastic surgeon can do in the face and the neck area, OMFS guys can do it too, as long as they get the proper training. If some programs are very heavy on cosmetics and these guys can do it straight out, other programs you'll have to do in a fellowship afterwards to be able to get the training to do so. This is again on the upper left side. You can see just how amazing a nose job can be in terms of some of the shapes of the nose up front here, and you can see on the right side just a completely different profile to our nose. On the upper right side, there's something called on the patient that they did was called a blepharoplasty, where they actually removed that excess lid tissue from those really saggy lids. When they get rid of it and they close it up, you can see it can give someone a much more youthful appearance. It makes their face look totally different when you remove that excess saggy skin. He also probably got a little bit of a brow lift too, where they lifted up the eyebrows a little bit to help give a little bit more of a better shape to the eyes. On the lower side, this is someone who had a combination of a facelift and a neck lift. You can see how it decreases just the amount of wrinkles around the side of the mouth, around the lips, not the wrinkles in her neck, and can really make someone look a lot younger. So if you're into that sort of thing, you can explore that through OMFS. Like I said, I'm personally not into it, but it's an avenue that you have complete access to in our specialty. And then kind of finishing up here, some of the really big surgeries that we do also are this head and neck surgery and microvascular reconstruction. So really, this is probably like the pinnacle of what we do as OMFS surgeons, minus the craniofacial, in the sense that literally any tumor that's involved in the head and neck area, excluding really cranial base, but even then some OMFS guys still get involved in cranial based surgeries or brain surgeries, excluding that as well. We literally go in there and working with multiple teams, whether we actually, sometimes we'll actually tag team these surgeries with ENT, plastics, or even other OMFS surgeons. And we'll actually resect large chunks of someone's head and neck because we have to remove cancer. Not only do we have to remove the cancer, we have to remove a certain amount of tissue around the cancer because we have to make sure that those margins are clean of cancer. Because if you leave any cancer cells behind, the cancer just comes back. So you can imagine it gets to be pretty large chunks of someone's body that gets removed. And when you remove these large chunks, you have to replace them with some part of their body to help replace those chunks. And one of the things we actually do is something called vascularized free flaps. And that's just a fancy word for saying we actually take chunks of skin and bone from other parts of the body, like someone's leg, someone's hip, someone's scapula in the back. We can take some chunks from the chest, from some muscle and tissue, and we actually will move it and bring it into the new areas in the face, head, and neck. And then not only that, we actually reconnect the vessels. So we actually connect the arteries to the arteries and the veins to the veins in the area to give that tissue its own blood supply. So it's pretty incredible surgery, and this stuff is done under a microscope that we actually do to help kind of reshape those vessels. Again, we do two types of it. Anytime you talk about head and neck cancer, there's the ablative side, which is a fancy word for removing or resecting that area of pathology. And there's the reconstruction portion, which I was mentioning, where we actually reconstruct the area from anything as small as a skin graft or little tiny excisions to something as big as a free flap, where we actually will move other tissue from some other part of the body, bring it in and reconstruct an area in the body with that tissue. For example, this is someone who had an osteosarcoma in the upper right maxilla. So you can see here, like on the left side of his upper jaw looks normal, everything's perfectly fine. The sinus is perfectly clear, but on this right side, it's a pretty opacified. This is all pretty much cancerous tissue all the way in there, extending up to basically his eye. This is an example of somebody who had a very large tumor growing on the right side of his jaw that was so big it spread up into pretty much the upper side of his face. And OMFS surgeons were actually involved with the resection of that area. And what we do is we actually resect it. We actually take these patients through these virtual surgical plans where we actually, we'll reconstruct this under a 3D model. And like this is an example where we're taking someone's fibula to help reconstruct the jaw. And we actually will get these things planned out down to the millimeter. And we actually get special cutting guides to cut the fibula exactly in the right spots, to bend the fibula in the right spot, and really get the best reconstruction possible. Like an example here, it tells us exactly where to cut in the jaw, and we have cutting guides that fit right over the jaw once we get it exposed, and let us cut the actual pieces properly. And then you can actually see, like measured down to the actual millimeters, just how much of the fibula we're removing and where the two segments are going to go. So they literally tell you A goes here, B goes here, and that's how you're going to bend it. And we actually have custom plates that we print. And these custom plates, we then go in there and they actually fit perfectly like a glove onto these bones so we get a really good end result. Not only that, we actually do nerve grafting where we actually reconstruct nerves. So the nerve that I was mentioning about earlier that runs to your jaw, it gives you sensation to your lip and your chin. When we resect this portion of the jaw, we can actually go back and use a nerve graft to try and give these people some of that sensation back. So they feel like things are normal. They're not just kind of this fat kind of decent or insensitive area of the body. We also do like some of the more cosmetic type excisions. So you can see, for example, somebody who had Mohs surgery for excision of like a basal cell carcinoma, a benign lesion in the face, we can actually go in there and design these special incisions where we actually, and that's from knowing our cosmetics training and our training in general in head and neck surgery. We actually reconstruct and give someone, rather than having a big gigantic gaping hole, they have nothing more than kind of a little faint line that's kind of tucked away into their ear and tucked below the ear, and that's all they see afterwards. So this is an example too of a patient who had literally a chunk of her nose that we cut out from cancer. And we actually did something called like a melolabial flap, which is where we bring some of that tissue from the adjacent side here, and we do these special little cuts to bring that tissue up and over. And not only that, also close the area there. And this is a phenomenal result. You can see here on her nose, the area that we excised, because there's two different skin colors here, but you can barely tell that we took some of the tissue from the side of her nose, and you can barely see any of the any scarring on the nose other than just the skin changes. Another example here is you can see here from a little excision in the nose, and we're trained to create these little flaps here to kind of help kind of move these things over. We bring one flap over, bring the other one over, and when it's all healed, very minimal scarring in the nose area. And then last but not least, and this is one of the cool things about being an OMFS surgeon versus an ENT and a plastics, is not only can we do everything that they can do in the area, but we actually can one up them. Not only can we replace their jaw with a vascularized free flap, do all the microvascular, do all this crazy surgery, but we can actually place dental implants into the area there as well and begin the process of rehabilitating the patient and giving them the ability to function again normally like a normal jaw. Because that's one thing where when these other surgeons will finish, they'll kind of refer the patient out, but we can actually do it all for them. This is an example where we actually placed implants directly at the time of surgery, where we reconstructed the jaw. So in 6 months, as everything heals, we can actually give them a new denture and let them start chewing again. And then robotic surgery, this is something that's kind of more rare, but some surgeons are trained to do some of these robotic Da Vinci surgeries as well in the OMFS field. So it's pretty cool because you can actually reach little areas in the head and neck that you can't really reach with your hands, just with the robotics, and be able to actually cut little benign tumors off the airway or things like that. And then one of the other things, like I mentioned this earlier, we can do tracheostomies, which is like those emergent airways. We do them immediate airways, elective, like in some of the cancer cases when we're doing surgery, or emergent, where if someone's coming in, they can't breathe at all anymore. We actually are trained to take them to the operating room immediately, get in there and give them a new airway. And then anesthesia training itself. So I mentioned this a little bit to you guys earlier about, some of the general surgery training. But when we're on general anesthesia, we actually function as a straight up anesthesia resident. So it's not like we're just sitting there and watching the anesthesiologist run the case. We actually run the full case ourselves. So, for example, 2 weeks into my rotation, literally once I kind of got the hang of things, got the hang of intubation, I was running full cases on my own. The attending would be there for the induction. We'd put the patient to sleep, and then he would just leave the room, and it would be me running the entire case with like the orthopedic surgeons doing their surgery, or the neurosurgeons doing their surgery, or the general surgeons doing the surgery. And I'm handling the patient's entire vitals. I'm putting them, giving them appropriate drugs, keeping them asleep, and then waking them up properly at the end. So it's the reason why we're so heavily trained in this is because when you go to your oral surgeon, when they put you to sleep for wisdom teeth to be extracted, that's actually a very dangerous thing, and people don't realize it. But we're so well trained in our general anesthesia, we make it a safe thing. So that's the reason why we go through such heavy training, so you can feel comfortable going to sleep at your oral surgeon's office without worrying that this doctor doesn't know what he's doing. So that kind of concludes the entire kind of presentation about what we do as a specialty. I just wanted to touch really quick just on some of the personal challenges that I had, just to kind of maybe some of the things that you guys can kind of, jump into a little bit on your own. But I kind of myself, I never really understood what OMFS was going into dental school. And so I thought I knew, so I knew I wanted to be an OMFS, but I didn't understand the full scope of what OMFS was, or just how competitive it was to get into OMFS itself. OMFS is a very competitive field. We have to take something called a CBSE, which is a comprehensive basic science examination. It's a really, really tough test. And it's something that if you're not committed to, or something that you don't truly are passionate about, it can be very tough to do well on this test, and it can be tough to, accomplish your dreams of being an OMFS. So for me, originally, I didn't really take this test as serious as I should have because I didn't understand just how competitive the program was. But eventually, I kind of, got my head back in the game, realized what it took, and thank God I'm where I am now. Another thing too I had with some of the personal challenges were not just how competitive the program is to get in, but once you're in, I mean, guys, I'm not lying to you when I tell you that OMFS program makes your dental school time look like it's a walk in the park. I remember I sit there and reminisce about undergrad, how undergrad I felt like it was literally like I don't remember even undergrad, any part of undergrad being difficult. Despite that, if you had asked me 8 years ago, I would tell you undergrad was tough and I had all-nighters and all this stuff. But OMFS is very challenging. You're on call where you can be on 24-hour shifts and you can still be in clinic the next day. I remember the longest I ever worked was like 39 hours straight where I didn't sleep at all. And it was just like nonstop, seeing trauma, consults, all this stuff. So the specialty itself is very challenging from that perspective. So if you're not good with in terms of a personal schedule, if you're not good with being able to manage your time properly, which I sure as heck wasn't at first, I really struggled. So any advice I can give you guys is start to develop good habits now. So if you do decide to pursue this field, you're not only going to be comfortable studying hard for this test, comfortable handling the rigors of dental school while also trying to get an OMFS, but also when you get into residency, you'll also have these good habits that'll help you succeed as a resident as well. Because I had to learn all that the hard way. And then tips to you all in terms of like your time going through, in case I piqued any of your guys' interest, is don't close the door too early. A lot of you guys may not be interested in doing OMFS when you first get into dental school, but I've met so many people that when they get into dental school and start doing some of the dentistry side, they realize that, you know what, it's not really as interesting to me and I want to be an oral surgeon. But all of a sudden, they're year 3, they were messing around the first 2 years, their class rank is trash, they didn't really study for the test, and then they're scrambling and trying to figure out how to make it all work at the end. So my advice to you all is that if you have even a little interest in not only just OMFS, but specializing in general, just work hard from the beginning. Don't close the door in your face. Maintain a good GPA, maintain a good class rank. So if you do decide to pursue this specialty further, you can actually have the basis and the background to do it. The next thing is your name of your institution doesn't matter at all. So I don't care if you graduated from Harvard Dental, if you graduated from University of Washington, where I graduated from for dental school, or if you graduated from Midwestern University, a private school in Arizona. None of that stuff matters because ultimately at the end of the day, a lot of these programs are looking at the CBSE test as being the end all be all. So I actually jokingly say this, that if you can go to a pass fail school, that's probably the best decision you can make because you don't have to worry about class rank and GPA and you can focus specifically on just this test, which is carrying so much weight nowadays. But if you don't, that's totally fine. Do whatever school you want to do. But if it's when it comes to OMFS, your institutions don't matter as much as the CBSE does, as much as your letters of recommendation, your research, all the other stuff matters more than the name. So don't, break your back or don't be upset if you get into a dental school that you don't think is as quote unquote prestigious as the others. Um, Finding the drive is important. Whatever you can do, if you want to do OMFS, is just stay motivated. If you can just keep yourself driven, the rest will fall in place. For me, what helps me keep my drive to get an OMFS was being around oral surgeons, doing these externships, spending time with other programs, seeing just how much I love the field. And that kept me up one night to study. It kept me going through dental school when I felt like I couldn't go anymore. And then last but not least is absolutely, absolutely don't compare yourself to anybody else. It's very, very easy when you get, and you guys might be doing this already in undergrad, but when you get into dental school already itself is already competitive. And you guys are going to be top of your class in undergrad. But guess what? When you get to dental school, everybody was top of their class. Everybody was the best of the best. Everyone had 4.0s. Everyone did 1,000 extracurriculars. Everyone did all that stuff. So it can be very easy to compare yourself to others. But again, I always say people talk and show like Instagram, where it's always everyone's highlight reel. So people may act like they're great, but in reality, they may not be as good as they make themselves seem. So just focus on yourself, stay on your grind, keep to yourself, and just do what you got to do to get where you want to be. And then last but not least, when it comes to the LMFS specialty, and again, I hate to say this because everyone tries to like play it down, but the standardized testing is still the most important thing people look at is the CBSE. Then it comes your GPA and your class rank. Then they start looking at your research and your extracurriculars. So I can't tell you guys how important it is to really, if you want to do OMFS, start studying for that test early. And it's never too early to take the CBSE because oftentimes in dental school, your first 2 years are often your freest. And not only that, it's when you study your basic sciences. So if you can just use some of that knowledge you have from your basic sciences, continue that instead of having to relearn it later in your third year of dental school. You can do pretty well on this test if you take it earlier. Anyway, I know it's kind of a lot, and I'm pretty sure some of you guys are probably a little bit blown away about what we do because nobody again understands exactly just how immense the OMFS field is. So I tried my best to kind of condense it into this like 45-minute presentation. But if you guys have any questions at all, please don't hesitate to reach out to me. I love chatting with any pre-dentals or even dental students when you guys are farther along. My email is right there. It's soliman.sohaib@gmail.com. Also, if you want to follow me on Instagram, it's at Egyptian Surgeon. I'm Egyptian first generation, born to two immigrant parents from Egypt, so that's where the handle came from. But I post a lot of my cases throughout the day. I just posted today about some of the cases I'm working on, so it's something if you're interested and want to kind of see what it's like to be in the life of a chief resident, you can kind of follow me along and see what you think there. Anyway, that kind of concludes my presentation. I hope I didn't go too far over time, but if you guys have any questions at all, please, I'm more than willing to entertain them now.
Okay, all right. Thank you, doctor. That was an awesome presentation and really insightful. So I think we can start with our questions now from the YouTube live chat, as well as Instagram, if that's okay with you.
Yeah, perfectly. Yeah, please.
Okay, so the first question someone asked was how you go about like residency and balancing your family life.
Ooh, that's a tough one. So it's actually funny. So I actually ended up marrying my wife after my intern year, which thank God, because my intern year was pretty rough. And so I was lucky that I didn't have to manage it then, which is the roughest year of your residency is always your intern year, your first year. But it was very tough because it's very easy to live for yourself. I remember like when I was an intern year, I would, I'd be exhausted. I'd be on this like 36-hour shift. But when I got home, I could just literally fall right asleep on the couch, order Uber Eats, wake up, eat it, and then fall asleep on the couch again, and then rinse and repeat in the morning. And it was very easy to be just about myself. But you can't do that anymore when you're married. Or if you have a kid, you can't just like come home and just say, "Oh, I'm too tired. I can't do this anymore." You just lay on the couch and fall asleep. Because when you get home, guess what? There's a wife at home who is exhausted from taking care of the kid all day, and she needs a break. And you can't just say you're tired. So initially it's very tough. I think the biggest thing about it is kind of planning your day around your family. So instead of focusing, and this is actually one of the mistakes I made, was that I made surgery and residency my number one priority, and that really affects your family life. So when I was able to kind of shift the two to being, I can incorporate the two together, I began just during the day. It wasn't just thinking about what I was doing today in the surgery, what I was doing in clinic. I would extend that thought process to being, all right, not just clinic, but what's going on tonight? What am I doing with my family? What am I doing with my daughter? What are we eating tonight? So it became like incorporating your family into your thought process. So that initially from the day you get in the morning, the moment you get out of bed, you're already thinking about your family the same way you're thinking about residency. So that was one way that helped me a lot. Number two is whenever I got home, I would usually, and sometimes you just need caffeine to make it work. I used to I would, I get a cup of coffee on my way there. I would have like a monster, it's bad, but I like Monster energy drinks. So I'd have like a Monster energy drink on the way home. So when I got home, I wasn't completely exhausted and just burnt out. So for me, it was like whatever it takes to make your family at that same level as your residency, and that same thought process can make you level the two in your mind and make it much easier to handle. So for me, it was just about making my family just as important in my mind as residency and making that part of my thought process. And the rest kind of just fell in where it was like I treated it the same way I treated the residency, where I'd be prepared, be involved, be active, and be present. Especially when I had my daughter, it was very much I wanted to be, active in her life and be there, because it can be very easy not to be there when you're in residency.
Okay. And then another question was, do you have any like interview tips or like how to stand out during an interview?
Yeah, definitely. So this applies to dental school and to residency in general. So it's this is funny. My wife will make fun of me for this, but I actually love interviews. I don't know why. I just like something about being in there and being able to be involved in this and be in the hot seat. I love it. It's really weird. So not a lot of people are like me. They dread interviews and they hate it. I think there's not enough can be said about being confident in yourself. So one thing you guys all have to realize that when someone offers you an interview, you already have your foot in the door. They're not going to offer you an interview if they think you're a trash candidate or if they think that you don't belong to be there. You don't deserve to be there. So when they give you that interview, that should already in your mind put that level of confidence that these people want to see me, they want to hear from me, and they want to know what I'm about, because they may think that I'm a good fit for this program. So you got to take that mindset into the interview. When you step into that door, when you see that person in front of you, that guy, that girl, whoever is there in front of you, that doctor that's interviewing you, right off the bat, you know that they want you there. They just want to make sure that you're a normal human being, and they want to hear about you, and they want to ask you questions about your application. So that confidence can then be translated into your responses and your ability to discuss your application with the person in front of you. So that's number one. Confidence is absolutely everything. And when I talk about confidence, there's a difference between confidence and ego. It's not about ego. It's not about cockiness. It's just confidence in who you are as an individual and what you have to offer this program. The next thing is being absolutely comfortable talking about your weaknesses. When I talk about weaknesses, I'm not talking about just like, oh, yeah, people always tell you like one of my biggest weaknesses is I work so hard. I often tire myself out. That usual cliche stuff people say. Your weaknesses, I mean, you should be able to look at your application, look at your resume, and be comfortable talking about why you got that C in that one class. Because I got asked about, or someone asked me like, my DAT score. They said, you're a great applicant, but why did you score such a low score on this part of the DAT? Or they'll ask me like, and another thing about one of my classes, like, oh, hey, you had straight A's, but I noticed that you have a C in this class. Tell me more about that. So you have to really be able to assess your own application, be comfortable talking about your weaknesses. Not only that, not only talk about them, but addressing them, being confident and saying, this is what I've done to rectify it. This is what I've done to make it better. So for example, I'll give you a hint, or one of the things that worked really well for me was, I'm sure you guys probably started looking at the DAT a little bit now, but like for perceptual ability test, the PAT portion of the DAT, I scored really poorly on it. And I'll be honest with you, I scored really poorly on it because I just had to use the bathroom really bad and I couldn't focus. And it's all about focusing on that area there. So it's the only time in my life I've ever submitted questions blank on a DAT score, or on a test in general. So I ended up getting like a 16. I mean, this is bad. Like it was a really bad score. The rest of my DAT wasn't bad though. And so I went in there and like he asked me, he's like, listen, like you're a great applicant, but what the heck happened? Why is your PAT so slow? And I told him like, listen, I'm gonna be honest with you. Like I just really had to pee. Like I couldn't focus. So I turned in the test and I did bad. But I didn't just leave it at that and just make it as an excuse. I said, but I really do truly believe that PAT is not a direct reflection of who I am as a candidate. And let me explain why. And then I explained that I used to work as a CAD CAM crown technician in undergrad, and I used to design crowns all day, every day, and that was the pinnacle of PAT. I had to literally be able to design a crown in 2D, 3D relations. I had to design primary, secondary, tertiary anatomy, understand how it fits in the jaw, be able to design the margins perfectly to fit the preps. That way, the dentist can deliver a finalized product without having to redo it. I said that's perceptual ability. This isn't like this test doesn't indicate me. So that's an example of like, look at your weaknesses, be able to define and describe how you've done better and what you've done to rectify it, and highlight it with a strength. Don't just focus on the weakness. If you can keep confident and highlight your weaknesses, I guarantee you the rest will fall in place.
Okay, so that makes sense. And then kind of going along with the application advice, do you have any tips for personal statements? Because I know like a lot of people are probably working on theirs right now with the
Yeah.
application cycle coming up.
Yeah, personal statements suck. I hate writing them. They're just like the worst. I'm sure everyone always is like, "Oh, what do I write? How do I know what to write in this personal statement?" I'll be honest with you guys. These people read thousands of personal statements on the regular, and they're sick and tired of seeing stuff. So nobody wants to hear about, "Oh, I was in dentistry because I love to help people," or all this stuff, or like, "Oh, I went on this mission trip and whatever, and like that's how I peaked into dentistry. Or that's what I loved." Or same with OMFS, like, "Oh, I saw a surgeon do a surgery. It was so cool. I want to be an oral surgeon." Like they want to see something that defines you as an individual. Like what makes you you. Make it interesting, make it about yourself, make it personal. A personal statement should literally be personal. It shouldn't be written as like a document explaining or having to sell yourself. But just like talk about a personal experience, talk about how that shaped who you are as an individual, and then from there maybe that's how it piqued you into dentistry, why you think you'd be a good fit in dentistry. So for personal statements, for example, like when I talked about like how I got into dental school or how I got into dentistry altogether, I said anecdotally, I was literally just getting a filling in the dental chair. And I told the story. I was getting a filling in the dental chair. I wasn't even thinking about dentistry. It wasn't even on my mind. I wanted to do medical school. And the guy who was the CAD CAM crown technician before me just happened to be graduating and go to dental school. And the dentist offered me the job on the spot, said, "Hey, are you interested in coming to work for me? It's a good pay. That's it." And I took the job. That was my introduction to dentistry. But I was honest, I was frank about it. And some people laughed about it when they read about it in the interview. They said, "Oh, no way. So you never even thought about dentistry. You just happened to be getting a filling and that's how it happened." So it's a very like it's got to be personal. It's not like what other people will say. You want to make it about yourself and what made you you. So it's not there's nothing wrong with, being a little less, formal in your grammar, or being more of a descriptive and more of a story versus just kind of that usual boring kind of that stuff that people just spout out in a personal statement. So for instance, like I read as a chief and a senior level resident, I read through all the personal statements from these applicants to get into oral surgery, and I can't tell you how many of them bored me to death. It was the same old. I would like swear they all sounded the same. They all had the same stuff, and I would literally read 3 or 4 sentences in, and I would just kind of glaze over and move on to the next application. So personal, it has to be the number one part of your statement. That what makes you you.
Okay. And then what would you say is like the biggest difference between dental school and residency?
Oh boy, the biggest difference. um, okay, it's funny. I was about to give a non-political answer. I was about to say you're more of a human in dental school than you are in residency. You're kind of you're just like let me tell you this. Your personal time and personal space is definitely you're way more in control of it in dental school than you are in residency. In residency, you're pretty much at the mercy of your senior level residents, your chair, your program directors, and your pager when you're on call, where basically that pretty much dictates and runs your life. So the biggest difference for me is that like when it comes to just purely time spent is drastically different. I think like the most I ever worked in dental school, like sure you'd be on for like you might have a really rough finals week. Imagine if your finals week, like the amount of time you spent on a finals week, imagine if that was like that every single week. That's kind of how I would describe residency because not only are you the difference between OMFS and other residency programs, like, and this is what I think, and I'm not trying to rag on, periodontics or prosthodontics or endodontics, like all these other dental specialties, is that we're truly a medical specialty. So you can imagine somebody who spent 4 years in dental school, not having learned a lot of medicine, and then get dropped straight into a straight up surgical residency that involves 100% medicine. The learning curve is incredibly steep. So not only are you spending so much time on call at the hospital as an intern, but you also expect to learn literally all of medicine in a year. Not all of medicine, but enough to be able to function as an actual resident and actually be able to like speak to the plastic surgeons, speak to the internal medicine surgeons, speak to the neurosurgeons and not sound completely stupid. So you're the amount that you will read and learn in your first year is crazy. So for me, it's definitely the amount of time I spent on the field is completely different in residencies and dentistry.
And then I think we have time for one last question. So what do you think was like the most intense surgery you've observed or like assisted?
This is a good one. So I've seen quite a lot of crazy ones. I think if I can break it up into two parts, I'll give you guys because there's kind of we do such a big surgery. I think the craziest surgery I ever done was that facial bipartition. There was two of them where we literally I mean it's just incredible. You can literally cut someone's face off their skull. I'm talking from like here to there. And literally split it, move the eye sockets together, move everything together, advance it, bring it to where you want it, and then plate it. I mean, it just didn't make sense to me until I saw it. I mean, that's nuts. I mean, but it's kind of funny. Even though I saw that now, it wasn't as intense to me as it was as the stuff I saw when I first graduated dental school. I think for me, it was always, I think the one that always kind of blew my mind was the very first patient I ever saw. And I apologize if this is too much for someone. I'll keep it as PG as I possibly can. Was that when I graduated dental school, the first patient I ever rounded on in my life, first patient ever, was literally like I just got started the program. Next morning, 6 a.m., we're rounding, was someone who had unfortunately was just suffering from mental illness, tried to commit suicide with a shotgun and failed. So you can imagine just the level of trauma to the face. There wasn't much of the face left. And I remember like going on rounds and I walked into the room and the chief surgeon was like perfectly normal about it all. And he literally told me, he was like, hey, so I'd go ahead and change the dressing on this guy. And I was literally like pulling dressing, this like really long dressing out of these, like whatever was left of his face. And I remember just like thinking like I don't belong here. Like, what am I doing? Like, this is nuts. Like, what? This is crazy. I've never seen anything like that before. We see it in the movies, we see it in textbooks, but it's one thing to actually be there with the patient who's in pain while you're changing dressings, who's has been so traumatically changed by this gunshot injury. And for me, despite all this crazy surgery I've seen, that's still probably the craziest thing I've ever experienced in my life was that initial moment and that initial diving into the specialty. And that to me is always probably never going to change. I still think about it. Literally, I can play it in my head, like second for second, exactly how that dressing change went.
Okay. Okay. Thank you so much,
Yeah.
doctor. Those are all the questions we had. And yeah, we really, really appreciate your time and all your responses.
Yeah, no, thanks for having me, guys. I really appreciate it. Again, I apologize if it was too much, but it's a really cool field. I really encourage all you guys to at least keep your minds open towards it because it's a pretty awesome specialty. And it would be cool if you guys have any questions at all about anything, just don't hesitate to reach out to me.